Hello and welcome. I'm your host, Ramesh Kumar. This program is brought to you by the Healthcare Administrators Association, HCAA. For over 40 years, HCAA has supported third-party administrators and the self-insured employer industry through educational opportunities from leading industry experts. For information on joining HCAA, please visit our website at hcaa.org.
Are you tired of the lazy way to cut healthcare costs? Just increasing deductibles and copays? In this episode, we are talking to someone who calls that approach what it is, the definition of insanity. Host Ramesh Kumar welcomes Adam Russo, co-founder and visionary of the Phia Group, LLC, an innovative cost containment leader and attorney who represents employers and plan fiduciaries across the US. Adam is here to break down the secrets of delivering a great healthcare experience on a self-funded plan. You will learn why direct primary care is being called the best plan design choice for both employee retention and health, with studies showing a 13% reduction overall in claims spent in the first year alone, and how Adam's company, Phia Group themselves, a successful self-funded employer, leveraged direct primary care to personally circumvent a $6,000 to $10,000 ER bill for just $80 a month. The critical need for a complete employee mindset shift and a 5-year educational plan to truly win at cost management. Don't miss this powerful conversation on why increasing cost-sharing measures has failed and how DPC offers a path to long-term success. Tune in.
Well, Adam, I'm super excited to have you on our session. You are incredibly well known in the industry for the work you've done over the last 10, 12 years. But rather than me talk about all the accolades, we're going to talk a little bit about looking ahead, what employers should do, what brokers should be doing, where the risks and cost containment strategies are. I would love for you to pick from your journey one or two things that gives you the incredible credibility to share these insights today. Maybe it was something that helped you come up with the thinking.
First, I want to say thank you for having me on. It means a lot to me. But to answer your question, my journey of Phia started 25 years ago. Right from the beginning, there were two things. And again, how I got into self-funding was an accident. I worked for a firm that happened to be run by an attorney who represented ERISA plans. They were self-funded plans. So that's why I knew the SIA world, what a TPA was, and so forth. And early on, I realized two things. One, even though self-funding, even back in the year 2000, was being used by 49% of employers, no one would know that. It wasn't like information that everyone knows. Today, it's close to 68%. But most people that work for a company, if you ask them, are you aware your company's self-insured and what that means for the health benefits? I don't think most people know. That's a major problem, too. What I learned was the more I can do to promote the industry and the organizations within the industry. So if I'm able to help a TPA grow, if I'm able to help a TPA find ways to be more efficient, to bring in new talent, how do we get younger people to join the industry? I realized early on that being a part of, whether it's HCAA, TABA, SPBA, SIA, being involved at that level connects you with people who have a passion for what they do. Otherwise, no one that hates their job is going on the board for the healthcare track, right? Or the AI track or cybersecurity. People that are doing that are obviously well vested into the industry as a whole. So you have great connections. And then the speaking opportunities, no matter what day, no matter what time, no matter what conference, no matter the size of the crowd, I would show up. Couldn't afford the plane ticket, couldn't get a nice hotel. I'll never forget my first ever HCAA conference. It was in Vegas, which is the worst place to speak because no one actually wants to go to your session. And it was on a Friday morning at like 8:30, following an open bar event that one of the vendors was throwing. Like, who's coming? Nobody. But that's how it starts. You do one, do another one, and then eventually if you truly enjoy and have a passion for public speaking the way I do, that combined with making sure that the industry knows you're doing everything on behalf of the industry. You want the industry to get bigger, more publicity, have more advantages. Therefore, TPAs are stronger. More groups are interested in self-funding. More brokers are telling their groups to self-fund. So now my pool of customers just goes up. So that's what I think I've learned are the best ways to grow your company while being a respected organization. That people know when you talk, you're speaking on behalf of the industry as a whole to make it better.
Yeah.
Not just for your own personal gain.
I've seen you at various kind of places, events. And I think more than that, what has been really, really cut through to what you're learning on the front line, whether it's the helping TPA customers or from a legal standpoint or where you're seeing cost containment going, being able to bring those insights. And that's kind of what we're talking about today. So let me jump straight into it. So if you today, looking at 2026 ahead of you, what are some of the big areas you see strategies they can use to cut costs from 10 to 30%? Where do you see this happening in the coming year?
So it's funny you say that, right? It's a great question. And it really is an open-ended question. You can go anywhere with it. But let's go back to COVID. What's the best way for an employer? Remember, I'm a self-funded employer too. We started being self-funded with 30 employees. Now we have over 300 employees, and it's been a great self-funded program, which I'll get into. Right off the top, you have to really think about during COVID, if somebody said, hey, there's a way for you to lower your cost by 10 to 30%. Don't let people go to the doctor. People don't get treated. So during COVID, every plan had a great year from a standpoint of how much they spent. I remember being at a broker conference and brokers like congratulated each other for this fantastic year when it comes to renewals and spend, all their clients save money. And I'm thinking to myself, they had nothing to do with it. No one in this room, including me, had anything to do with the lowering the overall cost of healthcare claims by 10, 20, 30, 40, whatever percent, because literally you could not get an elective surgery. You could not go to the doctor. You could not have your normal visits, your normal checkups. And it went on for a long time, as we all know, sometimes 18 to 24 months. So yes, there's an easy way for employers to lower costs for next year, and it's by making deductibles even higher. So literally a person doesn't go to the doctor because they don't have the money in their pocket to pay it. Because the first 8,000, 12,000, whatever thousand isn't on them. You want to know how to get people to not go to the doctor? Increase copays, increase deductibles, limit benefits in any legal way you can. Right now, in many states, including where I am in Massachusetts, starting next year, many of the carriers aren't going to cover LGP1s anymore. At all. Not covered. Too expensive. So how do you cut costs, Ramesh? Don't offer it as a covered service. That's the lazy way. And what happened 2 years after COVID? Talk to any stop loss carrier, talk to any MGU. Catastrophic claims blew up out of the sky. Like never been seen numbers before. And it's getting worse and worse and worse because, as you know, how many people went on prescription drugs for antidepressants for the first time during COVID? You start taking pills, Ramesh, you know how it works. Now you're on 2. Now you're on 3. It's always a magic pill that's going to save the day. And you get people hooked on medications. You don't know the side effects, many side effects on everything. And it's led us to where we are today. I say, and there's a famous, pretty smart guy named Einstein, who said the definition of insanity was repeating the same thing over and over again and expecting a different result. What's happened in health insurance? We are literally doing the same thing over and over again, every year. Here's your network. It's a more vast network. This is a preferred network. Your copay's going up, your deductible's going up. We have to offset this every year. Premiums still go up. No one can show me and prove to me that by us increasing copays, increasing deductibles, increasing premiums every year is somehow going to bring us to success. It's not. People have to be willing to try different things. And if there was one mandate that you couldn't even do it because there aren't enough of them. And I want to make sure I disclaim this. I do not own any interests in any of these kinds of companies. I got no connection in any way. But the best thing I've ever done from a plan design standpoint, best, not even close, from a employee retention, for my own personal health, for my family's health, for my employees' well-being as well, and it was not easy because when we started it 3 years ago, there were 2 direct primary care doctors in Massachusetts, 2. And for us to set it up and figure all that out, explain to our TPA what direct primary care is, it's not concierge medicine, what it is, where you don't pay claims. So TPAs like that part, right? There's no claims to process. So that's good. But I have read studies that show that in the first year of installing direct primary care for your employee population, it reduces overall claim spend by 13%. First year for the employees. Well, we went a little bolder. I said, any employee and any member of their family that's on the plan, free direct primary care. We'll pay it. We pay the bill. Why? Imagine a DPC doctor trying to cut, now he's doing invoicing for 100 different patients, or 150 or 200. It's one bill. To me, you get a much better discount on volume. He or she knows, the facility knows, just like a hospital. Remember, we negotiate with hospitals all the time. They're a provider. You're going to get paid for 200 people once a month, every month, one bill, never got to worry about collections. You get a deal 25, 35% cheaper than what a monthly subscription would cost. Then you promote it. And why do I promote it? What people don't understand about direct primary care is they want you to see the doctor. That's a very different mindset. We're telling you, employee, go have your physical. And it's not 30 minutes, it's 3 hours. 3 months ago, I had pneumonia. I didn't know. And my wife sees me in my bedroom, basically can't breathe, like tears in my eyes. Okay? And I go, you got to bring me to the hospital. And my wife now has been so educated, the word education, I bring back to. She goes, why don't we call Dr. Tremblay, my direct primary care doctor? My wife 3 years ago would have been 911, ambulance, emergency room. She now has been changed. So he goes, yeah, bring him in. I go into the office. There's no waiting room. Walk in. First thing, they put me on a drip, an IV drip, just to get some fluids. Then, after he takes my blood, right there, blood work, taken, he says, the medication I would give you, I don't know what it's called, I forget. I was like literally dizzy. He goes, if you go to CVS and get it, it's going to take a day to kick in. I can just put it right here in the IV if you want. Yeah, let's do it. While that's going on, they give me a nebulizer for my breathing. Then the doctor leaves, comes back 2 minutes later with a bowl of chicken bone broth soup that he had put in the microwave. And he goes, this is the best. I drink this every day. I left there an hour later feeling perfectly healthy. There was no bill. There's no copay. I paid $80 a month to have access to Dr. Tremblay. No cost for the nebulizer. No cost for the IV. No cost for the blood work being taken. That bill, if I just went to the ambulance, went to the emergency room, got blood work done on a different floor, then who knows what else they would have done. What about at minimum $6,000 to $10,000? That's the experience with direct primary care. It's a total different mindset. Yeah. You don't wait 2 weeks for an appointment. You get an appointment that day or the next day. 90% of the time, you just do a FaceTime with your doctor. And it's the same doctor. It's not telehealth, which is different. But getting away from the primary care physician process, where they are incentivized to send you upstairs to get lab work, go to the 5th floor for your MRI. I call Dr. Tremblay and DPC doctors like him gatekeepers. They know your health plan. They know your copays. They're going to tell you, that drug that you're asking for to treat your acne, it's a brand. There's a generic where there's no copay in your plan. I think you should try that first. It's a total different relationship with the doctor. When they understand your situation, they actually know who you are as a person. And I can see how that pays tremendous dividends over and over again. But then once employees have access to this, it's like going back to the 1950s where doctors would come to your house.
Yeah.
So I would say the big bold change would be whether you do DPC or not, and people can always reach out to me about our experiences. Lower your deductibles, lower your copays, incentivize your people to care about the cost of care and quality, because right now, they don't at all. And I think that'd be the simplest change. People are brainwashed. It's so many facets. And they always assume that no matter what their broker says, that's it. Can never question them. Can never question your doctor. Can never question your broker. Get every other thing in your life that you do. You have cost, quality, that you look at in a blink of an eye, access to everything. And then there's health insurance. And then there's healthcare. So.
Sitting in the same seat, I did another podcast earlier today. DPC came out as the primary way of looking at the future. And to hear again, and this is with a TPA CEO who's seeing it in the data as well. And the number he quoted was 10% savings immediately in the first year.
Our employees and their families have health insurance for free. Ramesh, free. We have no premium. We have no deductible. I couldn't do that year one. Years and years of not 1 hour a year on a renewal enrollment process. That's what most employers do. Most employers spend 1 hour a year explaining to the population that is spending the second highest amount on your expense sheet. An hour about here's your benefits. Nothing on here's what you could do to put some money in your pocket. Here's what you could do. Like when you go to an urgent care, is it actually a real urgent care or is it a hospital disguised emergency room? They exist right here.
Yeah.
Difference in $2,000. When should you pay cash? When should you not? Just nothing. There's no education about what a member's options are. I truly believe you put a 5-year plan in place. You focus on education. You focus on looking at the data as you guys do so well. Look at what is that data telling you? And then building the plan based on what that data is telling you, not only what's happened before and likely to repeat again, but what are the new potential barriers and expenses that you can't even fathom today? You think anybody 10 years ago was saying, these are weight loss drugs, they're going to be really expensive. And it's going to be the number one driver. And carriers across the country are going to stop covering it. Like, who would have said that 10 years ago? So you never know, but there are obviously signs of what's coming.
Let's hear from the sponsor and take a quick break. You've been listening to incredible insights on the future of self-funding. But for you, the growth-oriented executive at a third-party administrator, a critical question remains. How do you turn these industry insights into market differentiation and real profitable growth? In a crowded market, winning new business against the big BUCA carriers is tough. You're constantly struggling with low member engagement and an overwhelming volume of tactical support calls. ZakiPoint Health is your digital co-pilot for care navigation and growth. We provide a multi-touch mobile member experience that drives 3 times higher engagement rates and cuts your administrative burden. But we know you need more. That's why we built the Zara AI suite to tackle your largest service challenge, routine provider and member inquiries. Using our voice, our portals, and AI bot technology, the Zara AI Suite cuts your provider call volume for routine benefits eligibility calls by up to 50%. This is a massive leap in efficiency and cost savings that directly impacts your bottom line. And the beauty of our platform is that it is integrated with your claims system to drive data-driven direction for members, providers, customer support reps, and employers. No more silos and questions about the integrity of your data. TPAs partnering with Zaki Point Health are experiencing over 20% year-over-year growth. We equip you with the differentiated tools to win new business, satisfy employers with clear ROI, and scale your operations. Stop struggling. Start competing and winning. Visit ZakiPointHealth.com today and request a demo to dominate the middle market. Let's get back into the show.
So we'll dive into some of the science, but I think DPC as a primary way of improving experience, you talked about education and educating your employee population as a big one. You also talked about the gatekeeper, where the DPC can be the gatekeeper. Can they have all this information? Can they really help the member? How can you make the DPC more, whether it's incentivized or informed?
You don't need to incentivize. It's all about, like you said, remember, a DPC doctor, that's why you haven't seen it grow as much as you would expect. Because I just think fundamentally, people that go to med school, they go to med school because they want to save lives. It's amazing, right? It's a beautiful thing. For me, no matter what, the fact that you're being so selfless and put another person before yourself in regards to making sure they're okay is just something that's very amazing for all the people that go to med school and graduate. But they don't teach you how to be an entrepreneur. They don't teach you how to hang up a shingle. Be a direct primary care doctor, you have to get your own customer base. There's no PPO list that's just given to you. So they're obviously incentivized to make sure that you have a good experience, a much more positive experience than you traditionally. And I'll tell you, that ain't hard to do. But here's the key. If you, as an employer, have the relationship with the DPC facilities, and at the end of the day, making sure the DPC docs even understand your copay tables. Just so you know, if they go generic, there's no copay for them. And tell the employees that. Tell the people this stuff. Tell them there's cheaper options. It might be that you need a branded drug. No question about it. But think about this. An MRI within a hospital system, and you know, anyone listening to this obviously knows about pricing. Hospital pricing, how just massive it is. An MRI at a hospital. So if I go to my PCP in the hospital and they send me upstairs to go and get an MRI, it's $3,000 to $5,000 for that MRI. If you have a deductible January 1st of $10,000, that's your money out of your pocket. They never tell you there's a freestanding MRI facility literally on the other side of the parking lot. Go there. Get the MRI, it's $400. And they're going to email the record to me, doctor, just like the MRI upstairs would email the record to me, the technician. And I'm analyzing the exact same thing.
Yeah.
In both situations. And it's a difference of $3,000 to $4,000 in your pocket.
Yeah.
That's a gatekeeper.
Yeah.
And in many systems, because more and more physician groups are being bought by larger hospital systems, there's more and more incentive for doctors to refer people within their own environment. I see it personally all the time, just in my own family, with my mom, with my kids. And that is a major, major driver. Because at least now you know that your doctor is giving you all the educational information, all the information. That's why there are some really good pharmacy audit firms, let's say, that say, you know what, it's okay to ask your doctor if this other drug would work. And people just don't do that. I just think from a behavior standpoint, it's almost like whatever the doctor tells you to do, the doctor tells you to go upstairs, you just go upstairs.
So I guess a big part of it is not just educating your employee population, how to have that data be available to your DPC doctor, or having that conversation with the data, look, my copay is this or whatever. So just overall education can be very powerful.
Let me give you the easiest way. What we do is, so we have, instead of enrollment meeting that lasts an hour, we do quarterly workshops. Again, we don't know Susie, right? We're not like in front of the whole company going, hey, Susie, you had a lot of business last month, obviously. But the data is going to tell us, hey, there's still 8 of you. There's still a bunch of people that are using an emergency room where you didn't need to. It's costing you $250 out of your pocket, as an example. Telling people what the options are. And what we do every year on the first one is we bring in the DPC doc to listen for 1 hour. Here's our plan. Here's our copays. Here's our deductible. Here's what's covered under branded. This is what generic. Blah, blah, blah. Explain all that to the staff. They're there, and then they're introducing themselves.
Yeah.
Say, I'm located here. When we had our flu shots, they come to our office, set up in the conference room. Whoever wants a flu shot, you don't want one? Great. You want one? Great.
Let's get from an overall regulatory point of view, as things are changing, transparency rules to PBM reforms. What are some of the things that are really helping employers now to contain costs? Where are you seeing some of the trends there?
From a compliance or regulatory world?
Yeah.
Put it this way, if the government does nothing at all, makes no changes, neither good or bad, you've already saved money. Because you're not doing amendments. You're not doing restatements. Nowadays, they have this thing called, we have our software that auto-populates. When I did the first plan doc at Phia, it was with a Word doc, typing out, okay? Every time the government tries to come in and fix something when it comes to regulatory or compliance, again, this is not a Democrat or Republican thing. This is just across the board. Doesn't matter. All it does is make lawyers money. More compliance work, more regulatory changes. How does a change on page 95 affect a change on page 62? It's mind-boggling. The best example of that are, everyone knows what an SBC is. It's a summary of benefits covered. Now, if you look at the history of SBCs, my company has made a lot of revenue. Not profit, but it's a lot of work, but a lot of revenue making SBCs. When it was created, remember, most of the politicians, I'm not saying all, but they've never actually had a real job or haven't had a real job in, like you do, in years. Let's make this 4-page document that summarizes everyone's plan. So Ramesh, you're too busy. You can't read 90 pages. You just have to read 4. So they thought that you could take a 100-page document and summarize it into 4 pages. Not only that, they go, it has to be like a 14 font because older people can't see that well. So now the font's bigger, 4 pages. Ramesh, those 4 pages now are all double-sided. And the font is like 3, okay? You need a magnifying glass. And here's the best part. Every summary of benefits coverage, because self-funded plans are so unique, they can't actually put a summary in 4 pages, double-sided. So instead, what the government said, I swear to you, well, it's not really supposed to be a summary of the benefits coverage. It's really an example. And now, on the document, on the SBC itself, it says, in bold, the only thing bold, this is just a summary. Please review your plan document if you actually want any detail. We've been doing SBCs every year since the ACA passed. Every year, every employer, every different kind of plan they have to recreate an SBC. And they've been doing it now for over a decade. Literally, not one person's life has been saved, and not one person died or was saved because of the creation of SPCs, which in my estimation, it's hundreds of millions, if not billions, dollars of expense.
Wasted
Mailing.
effort and time.
So it's done nothing. Because if you want to know, if you actually think about it, why does someone actually, this is where the politicians got it wrong. Why do people actually look at your SPD? You look at the plan doc only when your claim's denied or if you're not sure if it's covered. That's it. No one looks in their plan for good stuff.
Yeah.
Like, look at this.
Yeah. It's excluded. That special pregnancy, the 7th visit to the home is not covered. Oh, I didn't know that.
Are you, in that situation, are you going, hold on a second, let me read the SPC. What is the 4-page? You look at the plan. Biggest waste of money, taxpayer dollars. Trump could literally say, no more SPCs. And if somebody could show me one person whose life is now different because of that, in any way, I wouldn't believe you.
Broadly, you're saying it just adds costs, paperwork, this and that. Nothing is really
moved. If you
moved.
do real reform, if you actually have, so we did pass real reform. The hospital price transparency in 2021.
Yeah.
Thumbs up. Awesome. This is great. Now, I can make an argument without quality metrics, it means nothing, but whatever.
Yeah.
But the rule was passed in January of 2021. It's been almost 5 years. Less than 25% of hospitals have actually followed the rule. You're supposed to be able to walk into a facility or go on the website and see the prices for their top 300 procedures. 5 years, it's not implemented. So even in situations where I can give you good stuff to try to have more transparency, transparency leads to capitalism leads to lower prices. Look at LASIK as a great example of something not covered, prices going down. Flat screen TVs, not covered by your health plan, you got to pay for it yourself. Somehow, the same TV that was 10 grand is now $300. Your MRI, it never goes down. Oh, but you're right, most of it is the government not at all putting in rules in place that just a waste of taxpayer dollars.
So trying to bring it all together, what you're kind of saying, a CFO, let's say, is listening to this, really think hard about primary care, think hard about education, informing, think hard about lowering, rather than increasing deductibles, just lower them, give care, good quality care, and then have the right...
Encourage them to have that care. Encourage people to have visits to their doctor, to get mammograms. Encourage them to do things, to catch stuff before it spreads too much.
Yeah.
And that's what the lesson was learned in COVID, 100%.
Well, this is great.
There's one thing I want your CFOs to hear. You're going to love all these things, CFO. Lower costs. But you have to understand there's going to be a little bit discomfort or potential abrasion with HR. Because this is all stuff that's going to cause HR more work. A different sets of work. No more one meeting, sign up for gold, silver, bronze, move on. Now you want to engage with people. You want to tell. So either you have to increase your HR spend, I would say, which I think would be worth it. But you have to get HR on the same page as the CFO, because the reason why you don't see much pushback by HR departments to the brokerage community, hey, give us something better, give us something new, is because the way they're created nowadays, even in our office, HR departments, if anything, are getting smaller, not bigger. AI is being used for way more stuff than it used to be. Outsourced payroll services, you know what I'm talking about.
Mm-hmm.
So if you now put some energy back into HR and go, hey, you, HR, are probably the second biggest driver to lower our costs. Let's get the employees and their membership engaged to want to lower the cost of care. And now that HR department is not just looked at as a cost center. It's now looked at as a valuable contributing way to be more efficient and to be more profitable and to save money in your plan. But that's the initial rub.
The friction, yeah. So yeah, very much where the work has to increase as an employer. You have to put the right effort behind it. You went out there all the way to create that DPC kind of model and provide the different kind of plan design. There's a lot of work there.
So we have employees in 32 states. I still can't believe it when I say it. Okay. Every one of them has DPC. So when I hear someone go, well, we're in Montana. There's DPC there. There are options. We have employees in Alaska. I mean, there are options. And it's spreading, especially in the world right now, it has to change because we have a shortage of primary care docs. There's going to be a massive shortage. What 25-year-old doctor wants to be in primary care where they're spending half their time filling out forms? It's not where they want to go. And if you can bring that love for, instead of spending half your day filling out forms and trying to get around insurance companies, let's spend 100% of your day actually treating people.
I think that's also on a bigger macro level, as you're describing. And my sister is a doctor, my brother-in-law, and they complain about this all the time. They want to spend more time with the patients.
And they can't. And they absolutely can't. And it's so funny. My dad and I, probably the last 10 years, have become close, which is a great thing. But we have very different political views. But I tell him when he talks about healthcare, he's like, who's right? Should we be funding the subsidy for Obamacare and so that next year's renewal prices won't go as high? I go, neither side has a solution. When the Republicans say, take the money and give it to the patient and let them decide how to spend it, that's not going to solve the problem either because prices are still going to be too high. We got to find a way to first know what the prices are, know what the quality metrics are, and then actually have pricing that is transparent, quality is transparent. And then that will ensure that when insurance companies are negotiating with hospitals, either that they're getting a fair rate, they get it reimbursed correctly, but then it will lower the overall cost that the actual employers and employees have to pay for premium because the insurance companies aren't paying who knows what on an out-of-network claim. It's a system that's broke that we just have to wake up and say, we got to change it. And it's so funny. I explained that to my father, and I'm like, yeah, see, your party once in a while is actually wrong. See? And you agree. Because it's not politics. It really comes down to just human nature. And what people got to realize, it's so hard for all this to change in Washington. And here's the reason why. And I'll keep it quick. One of the biggest employers in most metropolitan areas in this country are the hospitals and universities. And more universities own hospitals now than ever before. So you got situations where if you're in, I'm making this up, Wichita, Kansas, you got 2 hospitals, you got 2 universities, let's say, do you want to be the representative or the state senator or the congressman that says, let's lower what we pay to hospitals? Are you crazy? They'll lose all their votes. The number one employer, the number one donor. You can't do that. And at the same time, they're not going to antagonize any of the insurance companies that are also giving them millions of dollars. The money in the system is what kills us. But in addition to that, hospitals are one of the largest employers in most parts of this country. That's why when people told me, oh, Adam, Medicare for all will solve everything. And I go, sure. You tell me what hospital right now is going to accept Medicare for all. They're building the new wing. They're adding another water fountain. They would not be able to survive. Some of them would, like the ones that actually cater to Medicare, like in Florida or in Arizona. But in most parts of the country, we told regular women, all your patients now will be paying at Medicare plus 0. Okay.
No.
It won't fly from the hospital side either. So I just think people need to be more educated on the whole premise of it. And until we do that, nothing's really going to change when it comes to lowering overall costs unless we start slashing benefits, which is what many carriers here in my state are doing for 2026 because they're like, all right, what's our options? This is the easiest one, and it's the only one in our control.
Takeaway for the broker and the employer is also use some of these cost and other information. Do work with methods like primary care. Do educate, and that's how you're going to get to that next level and the next level.
Ramesh, who's going to leave you? If you are an employer, think about it. When I saw my company start to change from a demographic where, Ron is having a wife, he's getting married, having kids. I'm getting married, having kids. People are starting to grow families. When I'm 25, I couldn't tell you the name of my insurance company. I don't care. Now, when I look at our employees, if you are a woman or a man here and you have a family plan at Phia with 6 or 7 people on your plan and it's free, where are you going? What company are you leaving to? I mean, think about the salary difference you have to make.
Yeah.
To leave. No one leaves. And if you think about how much your human resources department, where you have the person, the hiring a manager or the recruiter, whatever you have in-house to identify talent. Look at how much it costs you to first job description, advertise, interview, multiple interviews, on board, training, and then 6 months later, they're ready to go. That costs $20,000 to $25,000 per employee when you do that. What does it cost to offer better health benefits and keep that person from leaving? A lot less than $25,000 a year if you do it right. So that's my speech for the year. I realize we're going to start something new, and there are things that work, and there are plenty of things that don't work, and doing the same thing over and over again is not going to change it.
Absolutely. Well, this has been great. Really insightful conversation, and really appreciate you using your kind of experience and example, not just over the whole 23 years of helping customers, TPAs, but also how you have done this innovative work at your company and helping employees. Thank you so much for taking the time today.
Hey, again, I'm humbled and honored to do this. It means the world to me. You're a great man, good friend.
Thank you, sir. Have a good day.
Thank you.
Please join us again for another podcast in the series brought to you by HCAA's Voices of Self-Funding. Please like and share so we can build a community of like-minded people, and tell us about topics that we bring to you next. Please watch your email for updates on upcoming guests. I'm your host, Ramesh Kumar.